right, 9:06. So hopefully everyone can hear me well. Good morning, everyone. My name is Henriquez. I'm one of the faculty here at Emory University Hospital down at Grady, one of the county hospitals in Atlanta, Georgia. For a change, I'm in my office and not at home, so this is actually great. And I think this is a great opportunity to share a little bit of what we all do, and hopefully you guys find it useful. I'm going to be talking today about kind of trauma, specifically midface trauma. Even though I'm a radiologist by trade, I get to do a lot of trauma. A little more about that later. Let me click on okay. I got no disclosures except for the fact that I am faculty for the AOCMF, which is a facial trauma educational society, and that you probably have heard of. If you don't, you should. It's a great resource for teaching and education. And I do, get royalties when I speak for them. Not today though. And this is our new trauma. Some disclosures, I am wearing pants indeed. I've been doing so many Zooms in my shorts, but today I am in my scrubs in my office, so I do get to wear some pants today, so that's great. As I mentioned, I work at Grady Memorial Hospital. This is our big county hospital, level 1 trauma here in Atlanta. And as I was saying, even though I'm a radiologist, endoscopic skull surgeon by trade, I do a lot of everything just because, as you may know from a county hospital, you deal with whatever works through the door. And I do a fair amount of facial trauma, which is one of my passions. So that's why I wanted to give you this topic, because sometimes facial trauma is not the sexiest topic at all. And I felt like even through my residency years, it was sort of taught in a resident to resident fashion. So I do have some things I want to go through today. We're going to talk about some anatomic perils, a little bit of history and historical perspective, which I always find interesting. How do we diagnose and classify these fractures? How do we manage? And to do that, we're going to go through some cases, mention some new technologies, or maybe not so new anymore, but some things that we use now, and a couple of slides and just things to keep in mind in this era that we're all trying to work with, which is the COVID-19 pandemic. So if you have your cell phone, I haven't used this. I don't know if it's working. Hopefully it is. But see, I want to just ask in general, people that are online, and let me see if this works. Can you see this? And if you can, text to this right here. And I'm going to see somehow my Zoom. So can you guys see that? I don't see any answers yet. So I don't know if it's working. Oh, there we go. So far, people are saying that they don't. All right, 50%, yes, they do. So we got about a 50-50 so far. Well, I'll give it 10 more seconds. Okay, there we go. All right. So look at the majority of you guys do, 86% do facial trauma, going up and down a little bit. Okay, good. So hopefully this will be relevant for most people. And for those of you that don't do it, I think it's still something to know because it's part of your training as an ENT. So, all right. So what will we not be covering today? So, I'm not going to talk really about nasal fractures isolated. I think you can have a whole topic on that. I am not going to be talking about orbital fractures specifically also, because I think that's a whole, even though it's midface, it's going to be, it could be its own talk. The handling specifically of soft tissue, big soft tissue trauma. Sorry for the gross picture if you are having breakfast yet. I'm not going to be touching base on ballistic injury, which is a whole different consideration. I am giving a talk through the Corona Initiative next week on this topic. So hopefully you guys can join in. I also don't want to spend much time in NOE fractures because this is a very unique kind of fracture that deserves its own topic. So the cases I'm going to present to you doesn't have much of this. So let's start with some pearls from anatomy. And this is a little phrase that my chairman, Dr. Doug Maddox, has in his office. And I think it applies to any surgeon that's doing any kind of surgery. And as you all know, when we talk about the midface, we're talking about this area of the skeletal skull base, which basically includes all the pair bones of the maxilla, palatine bones, the zygoma, the sphenoid, the inferior lateral part of the orbital rims. And it's a pretty special area because number one, you have a ton of muscles, so the facial expression that attach around this area. And so another thing is that of our 12 cranial nerves, 6 of them basically go through this area. So injuries of this area usually come with problems with this. The other thing is that small deformities in the midface are very noticeable to the human eye. So that's something, that's why you want to get it right. As you probably heard or studied for your in-service exams, the way that the midface is supported is by these facial buttresses of the midface or struts. We divide them in horizontal and vertical. Horizontal, we talk about the supraorbital or the superior, the infraorbital or middle horizontal, and the zygomatic arches and maxilla, which is I call them inferior. So I usually, when I ask my residents, instead of these names, I say superior horizontal, middle horizontal, inferior horizontal. And the mandible also plays a role as a hole in the face, not the big. And then we have the vertical ones, which really are the most important ones that you want to restore when it comes to facial fractures of the midface. And we talk about the middle one, or the nasomaxillary buttress, the lateral one, which is the zygomatico-maxillary buttress, and the posterior one, which is basically your pterygomaxillary or pterygoid plates right here. So again, the way this works is it's like a tent, right? Where these buttresses, these buttresses basically work as your tent poles, and the actual tent is the soft tissue of the face that sort of gets draped around it. So for the most part, if you are thinking about, okay, in terms of which buttresses do I have to restore or fix, the soft tissue will follow suit. There's also something to keep in mind, which is just a suspension of the soft tissues, and we're going to touch base a little bit about that as we go through the cases, of course. So how do these patients present? Well, nowadays, we talk for one of CMCs, fractures, that we're talking mostly low velocity traumas, assault, ground level falls. Anecdotally here at Grady, at least, we're seeing an increase of these kind of traumas, especially assault, sadly, on the COVID quarantine pandemic, possibly because people are just at home, and I think, the fights happen. When you look at more complex one, like the 4.213s, which we're going to get into that, it's more high velocity traumas like falls from more than one story, high speed MVCs, and of course sport injuries. This is a picture here of one of our soccer players in Atlanta United that broke his nose a couple of years ago, and I was wearing this mask. I'm sure you've also seen those in the NBA players that wear those. Another thing is that, in the advent of things like airbags and seatbelt, the incidence of midface trauma has not really gone down in facial fractures. What has gone down, what's changed though, is the type of facial fracture. So for example, NOEs. NOEs is something that, I work full-time in a level 1 trauma in one of the biggest cities in the US. And I see probably a handful, less than a handful, probably 2 or 3 true NOEs a year. So they are not that common anymore, mostly because of airbag. You see them, but not as much as before airbags. If you talk to my colleagues that used to do these kind of cases before the airbag era, we used to see NOE fractures every week. So that's why when you see these talks and books about NOE fractures, sometimes I haven't done a suspension of a medial canthus in a long time, probably a year or two. And these are typical pictures of what you expect these patients to present when you see them in the ER bay, usually kind of this flattened look, these raccoon eyes. But at the end of the day, if your practice is like ours, 99% of the time when we get consulted, the patient already has a CT scan finding. So you are rarely diagnosing these fractures without imaging at the time that we, as a consultant service, are seeing these patients. So these are some maneuvers to keep in mind when you're in these patients. One of the things you want to always try to establish is the maxilla mobile. If you're thinking about a midface fracture, of course, a good example of the extraocular muscles. This is a lot harder to do in an awake patient with a real fracture, as you might have known already, because it hurts. It's a little bit easier if the patient somehow has been already intubated and you're seeing the patient in the ICU or already sedated, but it's really hard to do that. So sometimes we do this really in the OR just to confirm the mobility of the palate. It takes a lot of force for most of these injuries to happen. So you have to think about other injuries that may be going on. So make sure that you're checking for the spine injuries, skull-based injuries. Again, NOE is probably the most common missed fracture when we're looking at midface fractures. People don't think, sometimes they don't want to look for them because they're hard to treat sometimes. Of course, the mandible, if it's a mandible fracture, that might change the way that you're going to approach this case. And if it's orbital trauma, always get an ophthalmology consult. They might complain about it, but it's gold standard that we want them to put a note and do an exam before we do any sort of instrumentation around the midface area. So how do we classify the midface fractures? Well, you know, you all heard and use, I'm sure, the Lefort. Interesting story topic. So René Lefort is a French surgeon. He was actually an orthopedic surgeon, and that did his seminal work was actually on injuries of the maxillofacial area, and this is the original study. And but you know, you'll be a little bit disappointed if you heard the story that, you know, he took cadaver heads and threw them off the balcony of a building and then saw how they fracture. He actually did not do that. You know, he actually did most of experiments on whole body cadavers, so they were not decapitated. He did hit the heads with things like wooden clubs, the corner of a table, a marble table, and then he documented the way that these fractures mostly happen. And he talked about these quote unquote great lines of weakness around the face, which is basically the patterns of the Lefort fractures that we still know and talk about today. So we all do the three types: type 1, type 2, type 3, depending on which buttresses are affected. The common denominator of a Lefort fracture, and this is something that I want you guys to learn, is it has to involve the pterygoid process. So a lot of times the radiologists will call the Lefort fracture, but the pterygoids are not really involved. And that's important because if your pterygoids are still intact, then it's probably not mobile or not mobile enough that's going to cause any issues. So you always have to have a pterygoid process, okay? The problem with the Lefort classification is that, you know, it's useful, we still use it, but not every fracture like this one sort of follows the pattern of a Lefort fracture, right? So sometimes it's not that useful. You talk about a hemi-Lefort 1 and a Lefort 3 on that side, which is not the way that the classification was designed to, but is the way that we use it. So there's been another ways to try to classify this fracture. One of this is the AO has this fracture classification system, which goes by different levels, 1 through 4. Just to briefly mention, for example, level 1, every part of the the facial skeleton has a number. When you move to level 2, it has a code. It's very complex and probably useful mostly for research purposes, but it hasn't really taken off as something that we all use clinically. I just wanted to mention it here. They do have this software, which I personally haven't used, just to tell you how, to be quite frankly, but you can basically kind of click the fractures that you see and it will give you this sort of code and classification. So something interesting. Definitely if you're doing some research, you want to standardize how you classify these fractures, I think is very useful. Just here, we're looking like, you know, the Lefort 1, usually, if you want to transform that into the classification, involves the, you know, the lower cranial maxillary skeleton. A Lefort 2 is going to be the lower pterygoid process and the inferior one. And then a Lefort 3 probably involves the upper, middle, and lower maxillary processes there as they classify there. Another, I'll put something here that's very useful. If you haven't used this, I recommend that you get to it. This is the AO User Reference Tool. You can download this in your phone or download this or just use it as in the web page. You click here and you can basically just click on the fractures, and it's a great resource to sort of get some tips on how to manage these different fractures, okay? So management is very important because as Dr. Paul Manson, which is one of the fathers of CMF trauma, he's a plastic surgeon all the way up in Maryland, you never really get a second chance to do a good primary reconstruction. So you want to get this right. Does anyone know who this guy is? So if you ever want to give a hard time to your plastic colleagues, tell me about Mr. Harold Gillies. I'm sure you heard about Gillies. He's an otolaryngologist, but he's considered the father of reconstruction of plastic surgery. So I always give a hard time to my plastic surgeons that, you know, we started their specialty. He was one of the doctors stationed during the wartime in Queens Hospital, and he interestingly performed the first reassignment surgery. Um, and but he, you know, War is a great teacher, as we're going to talk next week in ballistic trauma, sadly. And but he documented a lot of the injuries that he saw on the facial skeleton. This is some of his drawings and pictures, but pretty phenomenal. You can see this kind of Midface completely, and this is the kind of stuff that he used to use to reconstruct. So pretty amazing stuff, and actually pretty amazing results, to be honest. And even early on, you can see here he talked about the importance that all normal tissue should be replaced as early as possible and put it back into the normal position. And that is, I think, is key of any management when it comes to these patients. I don't see I don't see the oh, there we go. Yeah, there we go. I do see the Q&A just in case. Moving forward, in the 1940s, actually, also Milton Adams, you know, popularized this called the Adams suspension wires. We don't use this anymore, but this was basically going through the skin and using different wires to sort of suspend the bone. So it's an interesting thing. But, you know, what happened, thankfully, is that between the 1980s, we have a lot of advances, right? We had the resolution CT scan, which was a great tool to sort of like see this. We have the advent of plates and screws to be able to treat these fractures, and the development of more extended approaches, such as the coronal approach and things like that, which gave us a little better access and tools to treat these fractures. But the goals remain the same. You know, you want to reestablish, you always want to think about reestablishing the height and projection of the midface. That's key, okay? Reestablishing occlusion and reestablishing, if need be, the integrity of the nose and the orbit. The challenges is that sometimes these fractures are not isolated, as we talked. One of the specific challenges is that when the maxilla is impacted, and we're going to talk a little more about that. As I mentioned, keep in mind other injuries, because that might affect the timing of when you do these things. And of course, the presence of soft tissue injuries can be very challenging. You guys have hopefully seen this. They're very gruesome to use in the OR, the Royce and Patrick forceps. I put a special mention here because if you need to be able to do this, and don't be shy about using it. And this is a case, basically, when you see that flattened face, you want to be able to use these instruments, of course, with the patient asleep. This is not an awake procedure. And you literally just pull the patient up and try to disimpact. And the key thing is that if you don't do this and you fail to do this, this is why you look at the beginning, you have this like open bite, and then you want to disimpact and then establish the occlusion before you do anything else. If you don't do that, what happens is that if you have an impacted maxilla, you might still be able to put the patient in occlusion by sort of moving the mandible to fit the maxilla. But as you can see in this picture, that usually entails the condyles being outside of their joint. And then you do the IMF, and everything looks great, and then you take them off IMF after the case, and everything looks aligned in the midface, but then they end up with an anterior open bite. So that's why it's so important to do that. So my checklist usually for this patient is this right here. You know, of course, you go through your advanced trauma life support checklist. You want to define which kind of fractures you're dealing with. And then I always think about function and form. So function, you know, how's the occlusion, how's the orbital floor, and then the form, you know, the facial projection, the height, the width. Then I realize in my mind say, okay, which of these fractures I can repair by not doing anything, just about observing, which ones can I repair by doing close reduction, or which ones I have to do an open reduction internal fixation. Once you have a plan in your hand, then you have to think, okay, how am I going to manage the airway? How am I going to establish this premorbid occlusion? You know, what kind of MMF you're going to use if you need to, which buttresses I'm going to repair, how I'm going to access those buttresses. I'm going to have to do any bone grafting. For example, if the buttress is gone, not only broken, but actually it's completely gone. And how I'm going to sequence this. Some people like myself, I usually try to go from below up. Some people go from outside inside. And of course, special consideration about soft tissue resuspension, which I personally, in my career, didn't pay that much attention, and I do much more now. So we're gonna go through some cases. Again, have your cell phones ready if you can, because I have a few poll everywhere questions that we can go through here. This is the first case that I have here. You can see here Basically, I'll go through the scans with you. This axial view, bone windows, left side is zygomatic arch. Pretty depressed there on both sides. This is a 3D recon. Looks like a little bit of nasal bone fractured here. But let's focus specifically on this zygomatic arch right here. So keep that picture in mind. What I want to ask you is like, so what would you guys do with that fracture? Like, how many of you guys will just watch it and observe it? How many will do a close reduction? How many will do open? How many have no idea? How many will be, I put I don't know, because sometimes people don't know, and instead of guessing an answer, just tell me if you don't know. I'll give it 10 seconds. All right. 9 and 10. All right. So let's see. This is the breakdown that we have so far. So about a little bit over half of you will do a close reduction. About a third of you, a little bit before that, or a quarter of you will do an open reduction to fixation. And about 20% don't know. That's fair. So let's go back. So I probably would do a close reduction of this fracture. And the way that I would do this is mostly because I do think that you're going to have that significantly depressed, that when the swelling goes down, you're going to have a depression there. So that's an option that I would give the patient. I did not show up in any cut, but sometimes you have to be careful and see if the zygomatic arch is depressed enough that it might be impinging on the coronary process of the mandible, and that might cause some trismus and pain. And the way that I would approach that would be close reduction, because to be able to get to this part of, to do an open reduction to fixation to this, the only approach really that you have available is a coronal approach. That seems like a very aggressive approach just to fix this. You can't really go straight through here, because as we're going to see later, you have the risk of injuring your facial nerve. And the way that I would do, sorry about that. The way that I would do this will be most likely through a Gillis approach, which is very simple, to the incision by the temporal area. You can always do this to a Keen approach, which is a transoral approach. What might change one or another for me specifically is sometimes the timing of the fracture. So if it's a recent fracture, I usually try to go to a Gillis approach, just because it might be easier to pop it down, but you cannot really put a lot of pressure. If it's an old fracture that might be partially healed, you don't want to use the Gillis, because you can really put a lot of pressure on the temple area, and then you can actually fracture the squamous portion of the temporal bone. So for an older fracture, I actually might go transoral, because you can put a little more torque and more force in that. All right, so let's keep here. Case number 2. So again, I'll go through this here. This is a patient, let's say, was an MVC that hit the face of the dashboard right here. So we have the 3 reconstructions. In this view right here, you can definitely clearly see that which buttresses are involved. Well, as far as the vertical buttresses, both medial vertical buttresses here, the nasomaxillary buttresses are involved. Most likely also maybe a little bit of the posterior buttress right here. Okay, maybe a little one right here, but it's not displaced, but this one looks pretty intact. So for the most part, this looks to me as close as you can get to a Lefort 1. All right. So let's assume that you are going to do something about this. The trigger process is involved. It's mobile. You need to fixate this. So you're going to take this patient to the OR. So my question to you all is, you're going to take this patient to the OR is, I'm not going to observe it. Most likely, I'm not gonna do close reduction. I need to put some plates and reduce this. So, and this will be my plan in mind. But how are you gonna handle the airway? So I want to hear from you guys. This patient going to the OR. How are you gonna tell anesthesia? How are you gonna handle the airway? All right. So far, trach is winning. And I'll give it 10 seconds from now. All right, so let's see what we got here. About 8% said that they would do oral intubation. About almost half will do nasotracheal. About a third trach, and about 20% sublingual intubation. All right, good. So I think definitely if you're gonna, I wouldn't go with oral intubation, okay? Because I need to, if you put a tube through the mouth, and you leave it there, you cannot really put the patient on any sort of IMF to reestablish your occlusion, which is really what you're gonna use to guide your reduction. Somebody asked me, what's the timing of performing this? I would say I don't know if we're talking about this or the last case, but similar. As far as the timing of these two cases, I would do it as soon as possible if there's not any injuries. So within at least 2 weeks, 3 weeks. I wouldn't wait more than 4 or 6 weeks, because then you start having some callus formation and then bone healing that might be hard. So going back to the airway management, I probably would use one of these 3 options: nasotracheal, submental intubation, or trach. Me personally, I would do submental intubation. And the reason for that is because that's been a tube through the nasotracheal area. It might be on the way of me being able to reduce that fracture. I think a trach is probably a little bit too aggressive, although you can do it. This is something that us as ENTs are not that familiar. At least I wasn't that familiar until probably 4 or 5 years ago. But it's a great technique. And it really didn't make any sense to me when I used to hear this in the AO courses. Like, how do you intubate this patient to the mental area? Really what you do is that you have the anesthesia do a regular orotracheal intubation. And once you prep and drape, you make a small incision. And this picture is a little more lighter than I would probably do it. You make a small incision in the submental area right under the posterior cortex of the mandible. And now that you can basically put a hemostat that you're gonna find through your floor of mouth, cut the floor of mouth without injuring your salivary ducts, get the hemostat through there, and then you basically take the endotracheal tube, the front end, and just feed it through the mouth and just put it in there and secure it. And this is just to be done through the case. And at the end of the case, you just take the tube out and basically I would take the patient, just put a stitch there. So it's a great way of doing it. And we're gonna talk about the COVID era precautions, but I'm doing a lot of this in patients right now to avoid any sort of nasal instrumentation, even from anesthesia colleagues right here. The way that we approach this, let me see if there's another Q&A here. No, not so far, we're good. Okay. I probably would just do basically a maxillary vestibular approach that lets you get to those buttresses that we're trying to address here. And this is, again, disclaimer, these are all scans for me. You can see this is a post-op scan at some point. These results are not perfect. We got a good reduction here. I don't know if I would use this kind of plates, this plate formation right here. I don't know why we did that. You can see it still do plates right here. I probably would put a plate mostly around this area here. So one thing to keep in mind about the buttresses of the face that you're trying to reestablish, you also want to put the plates in the buttresses because that's where the thick bone is at. So this plate right here, maybe one screw is in this buttress, in this horizontal buttress right here. But you want to put screws in the anterior maxillary wall because that's just thin wall. So always try to put your screws in the buttresses, which are the harder bone. So here's, again, touching a little bit about the soft tissue resuspension. And as I mentioned, I didn't really pay much attention to this. Even as a resident or early attendinghood, I would just make the incision, plate it, and close it. But you have to do something to try to avoid that, because in this, for example, if you do a complete vestibular incision, you're gonna basically affect some of the ligaments and suspension of the soft tissue. You can end up with a wide nose like this. So you're gonna have flaring of the alar basis, the flattening of the base of the nose, and even some inversion of the upper lip. So a few things you can do is, one, when you're closing, you can do this cinching suture that you just basically put a suture around with some sort of like Vicryl or something like, or even Prolane even there. And then your mucosa, you can close that in a V to Y and sort of bring things together a little bit. So just keep that in mind more and more as you somebody here wrote in, sorry, the question going back, that depends on other injuries too, and that depends, yeah. I'm guessing they're talking about the timing, or I don't know if it was in regards to the timing of the airway management, but both. If this patient had the 4-1 fracture and but had another injuries, was already on the vent, intubated, was most likely going to require a trach, you probably would do a trach. But this was an awake patient, I probably would do submental. All right, third case. Let's see what we're doing in time. So we are 9:35. Good. So we're moving up here in a little complexity here. So again, another blunt trauma. You can see definitely here the three constructions, the buttress here, the fracture here, the CMC, a CMC on the right side, also a CMC display, CMC on the left side. Maybe a palate fracture here on the midline here. This patient is already intubated, so it already tells you the patient is on the vent. Not surprising because you can see even some fracture of the temporal bone here. So this patient probably is in bad shape, but stable at this point. So again, this patient we're definitely gonna repair, right? Let's assume that airway-wise, I would probably trach this patient if need be, most likely, because he's already intubated. So this is a patient I would probably trach. If this patient was about to come off the vent, maybe I can transform this into a submental intubation. But what am I going to do? Well, so let's look at the buttresses that I think need to be fixed. So I think from your lateral vertical buttresses, your CF sutures need to be addressed. Also, your maxillosigmoid sutures need to be addressed in both sides on that buttress. The medial vertical buttress also need to be addressed in both sides, and probably the infraorbital buttresses too. So thinking about how you're going to address all these different things, I want to ask you guys, what kind of incisions can you do? And let's see if this works out. This is an option. Just text me, and you can text multiple things. Text me the name of the approaches, that you would use for this. Transconch, vestibular, bicoronal, coronal. And let's see what shows up here. Let's see if it works. I'll give it about 10, 15 seconds. Let's see, I don't see anything yet showing up. Maybe it's not working. I don't know, maybe again, I never used this before in Zoom, so I don't know. It might not be working. Somebody's chatting here. Oh, yeah, if not use it, if this is not working, you can actually, the poll isn't working. I don't know why. But you guys can type in the chat of in the webinar chat. So I hear someone here will use the bicoronal and transconch. Someone will use bicoronal. Bicoronal again. So it looks like bicoronal. It's a approach. All right. Transconch bicoronal. Okay. So we have, yeah. All right. So the nice thing about the bicoronal, something you could use. The bicoronal, basically, I'm going to talk more about that. Will give you what does that give you access? Bicoronal. Let me go back to these buttresses here. Let me go back to. I don't know why it's not going back to my other one. So bicoronal, if you see the picture here, will give you access to this part right here, the CF fracture. Will give you access to the zygoma. It wouldn't really give you access too much to this right here. It wouldn't give you access too much to this, the medial vertical buttress. It will give you access to it if it's an NOE or nasal fracture here. So in this particular case, I probably wouldn't use the bicoronal. What I would use basically is to have access to this. I will probably use one of these two approaches, even a lateral brow approach, which is very easily, or an upper blef approach. It gives you access to this area and it heals pretty well. Then I will use a transconch, which give me access to this vertical, this horizontal buttress here. Okay, and you can use a transconch with some extension, specifically using a cantonomy, a lateral cantonomy extension of the transconch, give you a nice access to this whole area right here. Easier to play. And then for this buttress right here, I will actually use again the vestibular one. So I will use the combination of those three, and then basically the first thing is, this is just showing here how to reduce, two ways of reducing this, either with the bone hook or a Carol Durrell screw to put the CMC back in place. And I don't know if I have it here, but the timing of the sequencing of this is that I usually, when it comes to a CMC fracture, I always, once I reduce, I always plate this first, the CF suture first. I play with 2 screws only beginning, and then I go to the rest. And the reason I do that is because if I play this and this is still a little bit off, you still have some movement. But if you, sorry, my computer is acting up. If you play this one first here through the intolerant approach, then you're sort of stuck. That Sangoma is not gonna move too much. Again, talking about soft tissue resuspension, make sure that you resuspend if you can the periosteum, the muscles. It's very important to do that. The more you see these patients post-op, the more you realize that this thing does matter. And this is kind of our approach here, what we did. I played here with restologists too. Again, I'm not sure about these plates right here. How, this was all cases, why we put this T plate here. It did the job, but I probably would just put an L shape around this just to give you an idea. Let's see, we got a chat question here. Yes, so the order. So again, the order that I played, it's that first we will put this patient occlusion, number one. Number two, I would expose, let's see. I would expose all the fractures. So I would expose, do my CF approach here, my transcons, my vestibular approach in both sides. Then I will reduce the fractures I need to reduce. For example, this CMC was predisplaced. And then the first one I would play is this one right here, the CF. After that, I will play this one right here. And then the middle one here. And the last one will be the orbital one. I think the key thing is that these ones you can do a different order, but the first one should be this one in case you have to correct your reduction a little bit without having to replay the whole thing, okay? All right, case number 4, we got 942. So let's see here. So this is a patient that you see, this is a patient in the ER bay, so you can see the flattened aspect of it right here. The ER is sort of closed, a little lack in the face. And this is what we're looking here. This is kind of like a crush injury in one side. And then you can see, look at the buttresses that are affected. So the medial vertical buttress is affected. The lateral buttress definitely is affected. The horizontal vertical buttress here is affected. And then your zygomatic arch is just toast. Let me see here because I'm seeing one question maybe coming up. More, let me see. Q&A, sorry, I want to address these questions as they come. So somebody asked me if I put all patients with the 4 fractures in MMF, if so, how long they were in place. If the mandible is intact and I have a good reduction, usually not. I don't leave it at MMF. But if I do, I probably will leave them for it depends. I think it depends on the mandible fracture, to be honest. But I rarely put them at MMF because I don't think it gives you much. If I do, I will put an MMF with elastics maybe. I rarely put people nowadays on actually wire shot if I do a good reduction with good plating, okay? So back to this case. So again, pretty bad. Let me just take this. I don't know, my window here got weird. So how are we gonna approach this? Well, so let's first think about what we need to fix, right? So same thing, this buttress here, the CF fracture, the CF suture is affected. This one here is affected. The medial vertical one is affected. The horizontal one, the infraorbital is affected. And definitely part of the arc is affected. So again, this didn't work last time. So try it now, see if it works. He's doing something different. So it might be working right now. If we don't see anything in about 10 seconds, we'll go to the chat. But which approach would you use for this case? All right, it's working, it looks like. So Weber-Ferguson approach. What else we got there? Bicoronal. Bicoronal is bigger, it's winning. Okay. Bicoronal and vestibular. One of the transconjunctival approach, I'm gonna guess right here. All right, so I'm gonna give it 5 more seconds, but I think this gives us an idea. The bicoronal definitely is the most popular one. And I see the vestibular there, good. Let me see, I think there's some chat here too. So let me look at the chat real quick. Extender gills approach. All right. So yes, I would use the bicoronal approach in this case, plus a vestibular approach. And bicoronal, because remember, this is the area in the other side that we're trying to fix. We need to fix the CF. We need to fix the R. We need to fix this. If there's not much in the NOE, but it was an NOE, we probably could avoid that. And then I will also use a vestibular approach to give you access to this medial vertical buttress right here. So a few words about the bicoronal. You can do it different ways. So you can see here, this is an extension in the pericular extension, which I use a lot, especially if you're gonna, like in this case, if you need to play this like arch, you wanna extend that with the pericular extension. Again, just the plan you're working on depends if you're gonna raise a pericardial flap or not. For the sake of time, I'm not gonna go in much detail with that. I think one key anatomical pearl about this approach, as you know, is that once you start going down, you need to think about these temporal branches of facial nerve, which usually is deep to the superficial fascia of the deep temporal fascia. So a way to protect that, as you can see in this cadaver picture, is that there's two ways. One is that you can cut a little bit high up here where the muscle is, and then get under that fascia by seeing the muscle pushing out as you get to this approach, which is, this is the view you want to get. And by doing that, basically your nerve will be on the skin flap. Another way is to go a little bit lower, and when you see the fat, that temporal fat pad, just to actually make an incision deeper there, you can see the fat, and then go deeper. Same principle. You want to keep the nerve in your flap right here. But this is what you want to try to get to. This is the look you want to get in this case that I just showed you, to be able to play the CF, which is what you see right here, and hopefully reconstruct this zygomatic arc. Another thing that we did for this case, which is pretty cool technology nowadays, is this virtual planning, right? You can actually use this virtual planning tool with this segmentation of all the fractures here, the way they look. We sort of reduce them virtually to have an idea. And actually we did a model, which I actually keep here in my office, the same model from the same case. It makes for cool office decoration. But it gives you a nice idea of what you can do, and even you can even prevent your plates before the case if need be. I didn't use it for this case, but also image guidance is something you can do nowadays, and do virtual planning and load that to your image guidance, the same image guidance that we use for sinus surgery. It's a great tool to do. A cheaper way of doing this is if you have a 3D printer, you can actually do the virtual planning and print yourself the model of this. We have a study here doing 3D printing for orbital floors here over at Grady with the oral surgery and plastics. So that's another option too. Just going back to how if you need to do any sort of reduction, you can use these techniques. And one thing after you do the plating that we use a lot is I use intraoperative CT scanning. And this is something that you might have in your hospitals, you might not know about it. The spine guys, I don't know, I have the audio here, sorry. This was something that when I first saw it in a talk, I'm like, well, that looks pretty cool. And then I realized that we had it in my county hospital just because the spine guys use it a lot. And it adds about 10 minutes to your case, and you can actually get some nice images. Let me see if I can actually, there we go. I don't know, there we go. You can get some nice images of your reduction. And this is this case, basically. And you can sort of have an idea how good your reduction was compared to the other side, if need be, or compared to a pre-op planning, if need be. So I think I use this for every midface case that I do, for every orbital floor case that I do. Provides real-time feedback, gives you a chance of doing something in the OR. There's new scanners that are smaller. They don't have much time. If you know, this is just the amount of radiation that you get from this different kinds of scans. One paper that talks about revision rates is about 30% on revision rates, about 24% when it comes to CMC fracture, a little less than 4. The question with this data is always like, are you acting upon things that if you saw that on a post-op scan with a weight patient, you would be like, well, it's not perfect, but probably it's okay, maybe. So maybe the real rate is a little bit lower, but I do think it's a good thing just to keep, a good thing to keep as a tool in your armamentarium. Let's see, do I have another question here? No. All right, so going back to So tissue suspension, when you're done with your bicoronal, make sure that you're doing, suspending whatever soft tissue you went through, your muscles here, your fascia here. It's key. And this is kind of like your post-op of this patient. A lot of hardware. This is a rep's dream when you use all this hardware here. And again, it's not perfect, but it's as good. We decided I guess we decided not to do anything here. We could have put a plate right here and this one right here, but this was such a mobile segment, and this already gave a pretty sturdy backup to this patient. And this patient actually, we did keep, it looks like we have arch bars. So it looks like this patient, we did keep this patient arch bar. This is a post-op scan. I think that's for a CTA for a different option here. This is the way he looked in the clinic here. So I don't know if you remember the pre-op, he was pretty depressed here. Looks a little bit better here. How are we doing with time? We got about 10 minutes. So this is this is just to show you in this case, how we're using technology that we actually have used, for other stuff. Another thing that I've used a lot is endoscopic approaches. This is a quick video of a case, orbital floor, middle orbital floor case. Just want to show you. It might not show well in Zoom. So I'm gonna, actually it doesn't show well at all. So I'm gonna skip that. So I want to show you so just to end up, a few things about the management of CMF trauma. The AO has put out a guideline, and you can actually, if you go to the AO website, and the AO CMF website particularly, you can download these guidelines. If you have any questions about it. Same with any other head and neck procedure. So the overall recommendations are that we know from some evidence, not great, but some evidence that an instrumentation of the nasal and oral cavity is an increased risk for transmission. There's an important amount of patients that might be infected or are symptomatic. So if it's elective, or if you don't have a capability of testing these patients, you should push this a little bit until you can. Here we test every patient for, even without symptoms. If you're going to the OR for any trauma case, it gets a COVID test within 24 hours of their visit. It also gets a chest X-ray, and it gets a pulse ox monitoring. And the reason for that is because we still don't know the real false negative rate of our tests here in the US. Our Italian colleagues some papers are talking about 30, even 40% false negative rate. So hopefully by using a chest X-ray and a pulse ox, if something there that looks like a COVID chest X-ray, you probably want to be a little bit more careful. Specifically for midface, you want to consider close reduction whenever you can. Considering using a capillarized screw through the skin instead of using oral incisions if you can avoid it in the COVID area. Things like using scalpel over monoporic artery, avoid repeated suction irrigation. If you can use self-drilling screws, prefer. I did a mandible yesterday for an angle, and I actually did self-drilling screws for that. First time I've done that, but I have to do it. And if you do have to do osteotomies, try not to use saw, but maybe use osteotomes, which cause less aerosolization. I think I see a question here. So I see, could you discuss midface fractures in the dental patient? Do you need IMFs, palatal splints? So great question. So in patients without dental patients, again, it's harder to know the occlusion. If the patient uses some sort of prosthesis, I sometimes will put the prosthesis on the patient and use that to establish occlusion. I don't do splints, but my OMFS colleagues do splints in some hospitals. But usually IMS screws is fine if you can do that. If a patient is, sadly in a county hospital patient, I have a lot of patients that are homeless. They are dentalists, they don't care much about that. So there might be a little more forgiveness if your reduction is not perfect. So hopefully I answered that question. So some technical points now. We are 5 minutes from questions. Anatomy always is key. Always think about function and form. Function and form. Don't disregard the suspended soft tissue in these cases. Now we have some new technologies that are not so new, but maybe new as being used for CMF trauma that are really cool. And please keep in mind in this era, the COVID-19, that we have to be doing things a little bit different, specifically for the management of these patients. So with that being said, this is an old picture of me. I didn't change that. Thank you so much. And we have about 5 minutes for questions. If there's any questions, hopefully this was useful. And next week, I'm going to be talking about ballistic injuries. So hopefully you can see you there. So feel free to ask me some questions over the chat. All right, I'm getting some love from my own residents. Thank you.
Thank you very much. Appreciate it.
All right, thanks everyone for playing. Thank you so much for using the poll everywhere. It worked for the most part, so thank you.